Hello everybody. Welcome to number 1 Doctor channel. Today video is about peptic ulcer disease, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel number 1 Doctor. And join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about peptic ulcer disease. Anatomy and physiology of the stomach and duodenum. The stomach is an asymmetric dilation of the proximal gastrointestinal tract. The adult capacity is 1.5 to 2.0 liters. Anatomically, it is divided into the following parts: cardia, fundus, body, anteroom, and pylorus. The pyloric sphincter regulates gastric emptying and prevents reflux of duodenal content. The wall of the stomach has 4 layers: mucosa, submucosa, muscularis and serosa. The stomach performs 2 interrelated functions in the initial phase of digestion: A. Food breakdown to form chyme through mechanical digestion and acid and pepsin action; B. Reservoir through receptive relaxation, i.e. the stomach increases its size as the amount of food in it increases. Phases of gastric secretion. There are 3 phases of gastric secretion: cephalic mediated by acetylcholine secreted by the vagus nerve, gastric mediated by the hormone gastrin by G cells, intestinal mainly inhibitory through peptides like secretin. Pathogenesis. The pathogenesis of peptic ulcer is an imbalance in the aggressive activity of acid and pepsin and the defensive mechanisms that resist mucosal digestion. Factors contributing to the pathogenesis of peptic ulcer include: 1. Helicobacter pylori. 2. Nonsteroidal anti-inflammatory drugs aspirin. 3. Acid hypersecretion, for example Zollinger-Ellison syndrome. 4. Rapid gastric emptying. 5. Impaired duodenal acid disposal. 6. Impaired gastric mucosal defense. 7. Duodenogastric reflux. The most convincing evidence for H. pylori infection as a cause is that eradication of H. pylori infection is associated with a near elimination of recurrence of peptic ulcer following treatment. However, only a minority 10 over a lifetime of people harboring H. pylori develop ulcers. Classification. Acid peptic disease of the stomach and duodenum includes erosive gastritis, inflammation confined to the mucosa of the stomach. Acute gastritis occur after major trauma, shock, sepsis, head injury and ingestion of aspirin and alcohol. It is generally classified as stress erosion. Chronic gastritis peptic ulcers extend through the mucosa into the submucosa and muscularis. Chronic gastric and duodenal ulcers are distinguished by the presence of an established inflammatory reaction. Duodenal ulcer usually occurs in the proximal duodenum within 1 to 2 cm of the pylorus, the portion of intestine first exposed to gastric secretion. In duodenal ulcer there is acid hypersecretion, while in gastric ulcer acid secretion is either normal or decreased. Clinical manifestation. The clinical presentation is nonspecific and the following features may not always be found. On examination it is not unusual to find localized deep tenderness in the right hypochondrium. Investigations. A. Gastroduodenoscopy and biopsy. B. Barium meal. C. Blood studies. Dropping hemoglobin. Shows chronic blood loss. D. H. pylori test. Treatment. Medical treatment. Acid reduction. H2 receptor antagonists cimetidine 800 mg night for 6 weeks. Proton pump inhibitor omeprazole 20 mg. D. Irritants should be avoided. Anti-H. pylori treatment is given in the following manner if positive for H. pylori test: bismuth tablets, amoxicillin for 2-4 weeks, metronidazole. Relapses are treated with the standard treatment in cases of duodenal ulcer. However, gastric ulcers need endoscopic evaluation and biopsy to rule out malignancy. Surgical treatment. The patient is referred for surgery in the following conditions: A. Complications: obstruction, perforation or bleeding. B. Intractability, failure of medical treatment. Complications. Overall, in men, there is a 5% risk of perforation. About 10% of patients will have significant bleeding. Perforated peptic ulcer. Sex ratio 2 to 1, age 45-55 years, anterior surface of duodenum location. Past history of PUD is common. Gastric contents spill over the peritoneum and bring about peritonism, which will be followed by bacterial peritonitis after 6 hours. Clinical features. Sudden onset of abdominal pain. Pale, anxious. Raised pulse rate. Abdomen still, not moving with respiration tender, board-like rigidity. Liver dullness may be absent. After 6 hours, peritonitis issue with silent abdominal distension and patient progressively deteriorates to death. If the perforation occurs slowly, the presentation may be less dramatic. Erect plain abdominal X-ray, preferably a chest X-ray, may show air under the diaphragm. Treatment. Patient is resuscitated. Antibiotic therapy, continuous gastric aspiration and breathing exercise are also important. Urgent laparotomy done to do peritoneal toilet and closure of perforation with a mental patch. Anti-H. pylori treatment started to avoid recurrence. Definitive surgical treatment if symptoms persist. Bleeding peptic ulcer. Slight bleeding frequently occurs following trauma from solid food. Severe hemorrhage is due to erosion of an artery at the base of the ulcer located posteriorly gastroduodenal, splenic. Patient presents with hematemesis and or melena. Management. Conservative. For fluid resuscitation. Blood transfusion if indicated. Nasogastric tube insertion and saline lavage. H2 receptor antagonist. Endoscopic evaluation. Serial hematocrit determination. The patient should be referred for possible operation. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Artef Ahmed. My best wishes.